Hi, I'm Dr. J.B. Askew from Houston, Texas. I've been working in comprehensive breast centers for 20 years and more. And today we're going to discuss how we handle breast tissue, how we make the diagnosis, and how we endeavor to make breast care better for you and family members. We mentioned in the introduction we're going to discuss in this presentation what happens to the biopsy tissue after it leaves the lab. This is Dr. J.B. Askew, again, full-length picture in my laboratory garb where I operate as a pathologist in Houston, Texas. So who is this physician, Dr. Askew? Well, graduated from Baylor College of Medicine in 1969. I finished my residency in pathology, Baylor and Methodist Hospital in 1973. I was one of the founding members of North Houston Pathology Associates in 1981. Later, we began a comprehensive breast center at the hospital in 1995. There was a breast surgeon, a breast imager, mammographer, and a pathologist. We started the very important prospective breast conference in early 1996. Later, we began a regional breast conference that involved breast disease treating physicians from 4 different hospitals and clinics. The breast services expanded in 2005 with the opening of the TOPS Comprehensive Breast Center. Our group continued to add clients who wanted their breast biopsies done by our team. So what happens to the patient who is being worked up for a breast imaging abnormality? After the workup, mammographers decide that a biopsy is warranted. The patient is called in for a biopsy. The specimen is taken and quickly placed in formalin in a bottle. The specimen is carefully labeled with the patient's name, the site of the biopsy, birth date, physician's name. The specimen request slip is filled out with basically all of this information that goes on the actual biopsy container bottle, and additionally clinical history is written down for the pertinent information that the pathologist needs. The patient is told the specimen will go to the lab. But what happens to that specimen? Do you really know? The first thing that happens in the lab is that the request slip and the container are accessioned. And here's an example of the accessioning going on into the computer. This is the specimen container. Notice it has a tag on it. And all of the information that we were talking about must be on that tag, and it must be reproduced then on the specimen request slip. The ID on the specimen container is of utmost importance. The date of birth on the container must match the date of birth on the request slip. So there's a great deal of effort put into making sure that everything is accurate and that all of the data matches. So this, as an example, the biopsy site of the specimen must match what's on the tag, this little piece of paper, as well as on the request slip. So here's an example, the confirmation of the specimen ID. So we have the patient's name. Patient's name needs to be over here. It's covered up, as you can see. The doctor's name needs to be here. It needs to be on the container. The clinical history is here, the biopsy procedure, and the breast number. Now notice, now we've made this up, but this example is the accession number, S03, so that would be for 2003. S is surgical. And then the unique number is XXXX. And look, XXXX is here. And this special accession number is unique. And it will be on the cassettes where the tissue is placed for overnight processing that you will see later. That same number, that same unique number, will be also on the surgical pathology report. So there's a continuity of identification all the way through processing. How many cores are present? That's important. As we look down into the container, this is formalin that's present. The tissue is in there. We see 3 cores. These cores are white and firm, and they're lead-like, and we're going to talk about that in a minute. And that lead-like is like pencil lead. If you remember, it's very firm, and it doesn't bend or twist. And here's an example. Here's a breast core held in forceps, and this is upward. This is against gravity, and it's sticking up. So there's something unusual about this tissue. And the reason why is pathologists know that the normal breast tissue has a lot of fat in it. And if you look here, gravity is pulling it down. So it doesn't resemble pencil lead. Instead, it's very fatty and has not much substance to it that would make it rigid. So we inspect the actual tissue in the cassette. This cassette can go all the way through processing, and on its outer surface, it has the unique accession number that we talked about when we showed our example that was XXXX. So here are the tissue cores. We're going to describe the color and the texture of tissue. We can see here with the naked eye there's a lot of white tissue present here, which makes it firm. And these would be examples of pencil lead. If you held them at one end, they would stick upwards. We note if there's variation in composition, we note what is normal or what is abnormal. And this is all very important in the visual and tactile or feeling examination of the tissue. We measure all fragments. It's very important to document the size of the fragments that are taken. And so as we describe this, as we're handling the tissues, we mention and describe the color, the texture, and any other aspect that we notice, whether it's a localized change in one core, if it's widespread in all 4. And these changes may represent something significant that we will be looking at the next day under the microscope. So basically, you have witnessed the grossing of the specimen. This includes everything that we mentioned on the previous slide. One safety factor is that all biopsies are grossed in the presence of another person to ensure the integrity of the specimen. This just means that what was taken in the clinic is what is submitted in the container. It's very important. A control sheet is made for every biopsy fragment, and like we mentioned, the XXXX accession number, here are real numbers that are listed here, and it describes what kind of tissue is present and how many slides need to be cut. Once the tissue is grossed, it is processed overnight, and the processing begins about 5 p.m., and it's a deadline. Tissue that is recently biopsied, in other words, a biopsy at 4 o'clock in the afternoon, won't have sufficient fixation, and so it'll be held over in formalin and processed the next day. Most labs have modern equipment that automatically moves the soaking solutions that are in these containers down here. They are pumped up into a chamber where the tissue cassettes soak in various fluids in sequence, in other words, one after the other, and it's all controlled by a onboard computer. The fluids that move in sequence are formalin, alcohols, xylenes, and finally, early in the morning, the tissue soaks in molten paraffin. And that's the substance that the tissue sits in when slides are made. All the time in the lab, when new people show up, they say, "What's that smell?" It's usually people that have sensitive noses, and they find that the fluids we use in the anatomic pathology or AP lab are smelly and offensive. The first one is formalin. Most people know the name at least. And formalin is used because it kills all the bacteria that can cause tissue to decay. So we want to stop all breakdown processes as soon as possible. Formalin binds with the proteins to preserve tissue integrity. So we want it to look as close to normal in the living patient as it does when we're looking at it microscopically. Formalin increases the rigidity of the tissue, making it better for thin sectioning. Penetration into the tissue is slow and variable, and that is why on biopsies that are taken late in the afternoon, we allow them to sit overnight in formalin. This process is called fixation. What's that smell? Well, it's another fluid that we use, the alcohols. And the alcohols are used to remove water from the tissue samples. And if you remember from high school or college science classes, the human body has 70 to 80% water. So we need to get rid of that water in the tissue samples. And how we do that is using progressively stronger alcohols to soak the tissue samples. So we start out with 70%, which is 7 volume units of alcohol out of 10. And so that's your 70%. For 60 minutes, the cassettes with the tissue samples soak. Then we move it up. All of this is being done at night in the computer-controlled device. The fluids are moved in and moved out with precise timing. The next alcohols are the 90% for 45 minutes. And later, then 3 sequences of 100% absolute alcohol over a period of about 2.5 hours. The final product is the paraffin block, but the paraffin doesn't work well with water in the tissues. That's why we have to remove it using progressive alcohol. What's that smell? Well, the last fluid that we use that people can find offensive is xylene. Paraffin doesn't work well with alcohols either. As you remember, we had to use alcohol to get rid of the water. Now we need to get rid of the alcohols in the tissue, and that process we use xylene. So it clears the alcohol. Xylene slowly replaces the alcohol in the tissue. Xylene makes the tissue almost clear and transparent, and xylene works well with paraffin. That's very important. So the overnight processing finishes early in the morning, and in our lab it's about 4 a.m. So someone comes in, the early person comes in, very early, comes in at 4 o'clock and starts working with the material. So by the time the machine has used the formalin, it's used the progressive alcohols, it's used the xylene, now the tissue is ready to soak in molten paraffin. And after doing that for a couple hours, it finishes at 4 a.m. and is ready for embedding. And here's what you've been waiting for to see what embedding looks like. These are tissue fragments processed overnight, put into what I call a boat, and you see it go in there, and then it turns white. If you look, the paraffin's turning white, and that's because it's cold in that little spot. More molten paraffin's put on, and the block is put over on an ice bath. Here's another specimen, another piece of tissue. Put in there, watch the paraffin turn white. That makes it stick. You'll see it doesn't stick right away, so we leave it on a little bit longer. Now we put the molten paraffin on. So that's how paraffin blocks are made. Early in the morning. Then a little bit later we start cutting. So there's your paraffin block. You'll see the green that you're familiar with. And now he's cutting these extremely thin sections of paraffin, and the tissue is actually in the middle of that paraffin, and he's cutting what's called a ribbon, and it sticks together sort of head to toe, if you will. Now watch what happens when he puts it on the hot water bath. When his hand is removed, there are perfect sections, about 6 or 7, of the tissue and the paraffin, and he puts them on a slide, and now that slide is ready for staining. Before he cuts the next paraffin block, he carefully cleans the water bath to make sure there's no contaminants that would carry over to the next slide. Very important as a quality control method. So the slides are put into a holder and put on the stainer, and this process involves 2 stains and a number of alcohols and xylenes to do the 2-color staining that we employ. And that's hematoxylin staining, H&E, we shorten it. The hematoxylin stains the nucleus a dark blue, and the eosin stains the cytoplasm pinkish orange. So if we look at this slide, we will see a tissue fragment here. This is actually a cytology smear. The nuclei are blue, the cytoplasm is pinkish. We look at a tissue section, and again we see the same thing. The nuclei are dark blue, and the cytoplasm is pink. So this is a hematoxylin eosin stained slide. Once the slides are stained, they are put in a folder, and on the label is the patient's name and the accession number. Remember the XXXX, that will be on these, except it'll be the actual accessioning number. While the slide cutting is going on, here's an example of the slides that were just sorted. Here's one case, 3 of them. We cut 3 levels. Here's another, 3 levels. Here's another, 3 levels. So while the slides are being cut, the secretaries are madly typing up the gross description of the tissue that was dictated the day before. Once the slides are finished and the gross description is finished, that is given then to the pathologist to examine. We always have 2 pathologists looking at all malignant diagnoses, and here we have 2 pathologists, and they are looking at one slide in this area. It's something we do. Different pathologists come in and we all look together. As you notice, this pathologist is moving the slide around, and you may wonder, what is he looking at? And here it is. This is an example of what a malignancy looks like under the microscope, and we want 2 heads to look at that and confirm the diagnosis. We will, in later discussions in the next presentation, go over what's the difference between benign breast tissue and malignancy. The final diagnosis incorporates a number of things that are very important to make the diagnosis. The clinical history is provided by the mammographer who makes the biopsy, who takes the biopsy. The pathologist reads the gross description that was dictated the day before. He integrates the history and the gross with what is seen under the microscope. All three of these need to agree with each other, or there's discordance. This is something that's very important, and it's what is done daily by the pathologist. Discordance must be resolved before treatment can begin. Resolving discordance is done by physicians taking care of the patient. And it's very important that this gets resolved. An example would be a clinical exam and a mammogram appear malignant, but the biopsy tissue only shows benign, non-malignant features. Now this needs to be resolved because taking a benign diagnosis and ignoring the clinical and mammographic imaging appearance would be a mistake. So these issues have to be resolved, and sometimes a rebiopsy must be done to confirm what was found on the clinical exam in the mammogram. Very important. So the final diagnosis from a breast biopsy includes the location of the biopsy, be specific as possible. Here's an example, left breast, 3 o'clock. That tells exactly where the biopsy was taken. Be specific on the diagnosis of the disease. As an example, infiltrating ductal carcinoma. What you don't want to say is breast cancer present. There are many kinds of breast cancer, and you need to be specific. An example would be if you were out walking in the woods and you told a friend later you'd seen a wild animal. The first thing they would ask is, was it a mountain lion, was it a bear, was it a squirrel, or was it a butterfly? All of them are wild animals. So we need to be specific about the kind of carcinoma present. Special studies that we do in our lab are the estrogen receptor, the progesterone receptor, and HER2/neu. So this concludes our discussion and presentation on what happens to the biopsy after it leaves the clinic. There are a couple of things you need to remember. One of them is that we take exceedingly long time making sure that the integrity of the specimen is maintained. We went over that detail in the early part of this presentation. It was a little bit tedious, but the point we wanted to make is it's very important, and we take it as a high responsibility of our job to make sure that the specimen that was sent from the clinic is the one that we process. We maintain its identity and integrity throughout processing to ensure that the diagnosis that's rendered is on the right specimen. The other thing to remember is that on the usual specimen, it takes 24 hours to process. So that means that if it comes in on a Monday, in the usual case, the diagnosis will be ready late Tuesday. If special stains are needed or it's a more complex specimen, it'll take a few more days for processing. But after seeing this presentation, you should be able to discuss what happens to the biopsy when it leaves the clinic. Thanks for spending your valuable time with us. We do appreciate it, and we hope to have more presentations in the future. Thank you very much.